right now in society, if you have a revascularization procedure below the inguinal ligament, endovascularly, you have a 1 in 5 chance of having that entire procedure fail you in 6 months. And the reason for that is because we don't have great techniques to actually be able to tailor blood thinners after we've done a procedure. So what's happening is people take a patient to the operating room, they do the 6-hour procedure on them, they're high-fiving at the end because they had a great result. But remember, the whole point of doing the procedure is to get good blood flow so that you can heal a wound. That wound is going to take about 200 days to heal. So if you don't maintain that blood flow for that period of time, then you've really done nothing. And the mainstay of maintaining that treatment is by giving people blood thinners to ensure that things continue to flow. And because we do this one-size-fits-all, unfortunately, as I mentioned, 1 in 5 people are failing at 6 months and having to come back for another procedure, or worse, getting amputated. So what the target protocol is saying, let's stop doing what we used to do, which is say, oh, you got this type of stent, you need this type of blood thinner, because that's wrong. In the same way that it would be wrong for me to say, oh, you have a lump in your breast, you should just get this chemotherapy. That would be wrong. We would need to look at, see what was the genetic factors of that, what's your family history, what's your story, and then we would give you an individualized protocol for that cancer. In exactly the same way, I'm saying we should individualize the protocol for the blood thinners for these patients in order to maintain that blood flow so that they can heal their wounds. So what Target does is it literally targets that person's actual coagulation profile by taking a blood test, evaluating very quickly at point of care what their coagulation profile looks like, identifying what the issues are, and then giving the med that is appropriate for that particular issue. And in this way, we ensure that that particular individual is always appropriately treated with the right blood thinner so they can maintain their flow and ultimately heal the wound. We've implemented the Target protocol already. We did a large study where we actually sequentially looked at, in the beginning, over 100 patients who had standard of care therapy and identified, as I already mentioned, about 20% of them fail at 6 months. And then we went right into doing an intervention where we actually used the TEG machine to target blood thinners, gave the blood thinners to these patients, and then evaluated their outcomes. And when we compared their outcomes to the standard of care, we found that there was a significantly decreased number of patients who were amputated, a decreased number of patients who had thrombosis or stenosis, and a decreased number of patients that were dying from all-cause mortality by using the Target protocol. The only thing that was different in a negative way, so to speak, was that in the Target protocol, there was a higher incidence of minor bleeding. There were actually no major bleeding events. Minor bleeding would be like bruising or a nosebleed. And of course, that's what's going to happen in patients who are getting more blood thinners. But I would accept that little risk over losing a leg. There have been a lot of PAD trials that have been done, and a lot of them actually looking at things that are fairly important, but they make the cardinal mistake of not translating it out into the real world and disseminating it in a scalable way. While the science may be phenomenal, if you don't ensure that the environment in terms of logistics, in terms of patient journey, and in terms of cost are appropriately managed, along with government regulations, you will never get anything out into the market so that people can use it at a scalable size. So what we are doing is, in conjunction with doing the science, we are ensuring buy-in from the key opinion leaders by coming to conferences like this and discussing our work and getting input on what we are doing while we're building the plane, and simultaneously ensuring that the papers are published and being evaluated in top-tier journals so this can ultimately enter the guidelines. Because the idea is that if it enters the guidelines as the standard of care, hey, if you're going to have this procedure, you're going to have a TEG to ensure that you're getting the right blood thinners, then we can have benchmark and quality standards so that we ensure that no matter where you go to get your PAD care, you are getting the same level of pre and post care, along with, of course, the surgery. And in this fashion, we can put a quality metric across the United States, which ensures that the government will come in and say, hey, we want to ensure quality for everybody, so we're going to say that this is also mandated. And now the insurance companies from the US will say, oh, well, if it's mandated, we've got to do it. And in this way, we build the ecosystem such that it is easy for the surgeon to integrate this into their practice to ensure that the patients get the best results.